Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be an interesting and important session covering a very interesting question. Good embryos and poor outcomes. What can we do? As an embryologist, it's easy to focus only on the quality of embryos, but it's important to understand that we're still learning about embryo quality, and it's not the whole story. I'm joined tonight by a fantastic set of panelists who are here to help you better understand good embryos and poor outcomes. What can we do? They are Dr. John Hausken, Medical Director and Head Physician at Klinikk Hausken in Norway, Dr. Zane Vitina, CEO at EGV Klinikk in Latvia, and Dr. Raúl Olivares, Medical Director of Barcelona IVF in Spain. Now, I'm going to start by asking each of our panelists to introduce themselves and their clinic with an emphasis on what they offer in terms of embryo selection and what they would class as a good embryo. After that, I'll ask them, or tonight, I'm not going to ask them another question. I'm going to stick with this, what do we mean by a good embryo? So we're all on the same page, and then we're going to answer your questions. I'm hoping we're going to cover what the clinic can do to help you when you have good embryos, but things don't work out. If I can ask you please to put your questions in the Q&A box and not the chat, that'll help us to deal with all of them. We'll try to answer all of them, but I will prioritize ones that are easy to generalize for all patients, haven't already been answered, and stick to tonight's topic just in the interest of time. So let's kick off with Dr. John and ask you that question. Introduce yourself, please, and tell us what you consider a good embryo.
So first of all, I'm happy to be here. I love webinars. My name is John Hausken, and I'm from Norway, of course. I started with IVF in '93 because my father was one of the founder of IVF in Scandinavia. So I was raised with him and IVF from I was a child, and I'm still there. And I also I'm hands-on, so I do everything. I talk to the couples, and I do everything personally. So I'm not only the CEO. What is a good embryo? That is a good question, because also the couples, they ask, are my embryos good? So we use Gardner grading for the blastocyst, but we also use a timeline. And we know that timeline perhaps not will increase the success rate in the general population, but you will have a lot of how the embryos develop and the cell division. So we use timeline, and also at the end then a morphology grading of the blastocyst. And I would say everything less than 4AB is not a good embryo.
Okay, thank you. I'm going to come back to some of your points. That's super concise. Perfect. Thank you. I'm going to come back to that because I don't see any questions in the chat just yet. But let's let everyone else introduce themselves, and then we can address some of those things. Dr. Zane, could you do something similar, please?
Hello, dear colleagues and dear participants. I'm Dr. gynecologist, reproductologist from Latvia, Klinikk EGV, one of the biggest, I would say the biggest, one of six, but the biggest reproductive clinics of Latvia. We are a private clinic working with infertility and fertility treatment. We have andrology center and tissue cell center and andrology laboratory, and are the only ones which perform microsurgical sperm aspiration in Latvia. Yes, I'm not only the CEO, but also medical director, as well as gynecologist, reproductologist, and therefore I'm now the embryologist which evaluates the embryos, as you, Dr. Alan, but yes, first of all, the good embryo is selected morphologically, and it is a job of embryologist. We use time-lapse incubator as well, and artificial intelligence for help. And there are, the first is morphological features according the score, how embryologists evaluate the first digit according to the size of embryos, then the two letters, which first letter evaluates the quality of the internal mass of embryo, A, B, C, D. A, B is good enough. And the third sign or second digit evaluates, describes the quality of trough ectoderm. And AB is good enough, C is already lower, and then of course we look and seek for features, how embryo is developing, how it's divide, how the cells divide, whether embryo cells has vacuoles or cytoplasm is good enough, and fragmentation is evaluated. But if the person is over or close to 40, then good embryo is not only evaluated as only according to morphological features, but also evaluated according to appearance of aneuploidies. That would be my answer on your question.
Okay, perfect. Thank you. And I'm glad you touched on aneuploidy as another feature to consider. Okay, Dr. Raúl, it's over to you.
Well, I am Raúl Olivares. I'm the medical director of Barcelona IVF, based in Barcelona, as the name suggests. The clinic was opened in 2010, though we all come from another clinic. I've been working in fertility since 1994. And well, we are lucky that in Spain we can perform almost every treatment. We have a state-of-the-art lab in which we do time lapse. We use IA to identify the best embryos in terms of morphology. We use Gardner classification as well to select or to classify the embryos. But in my opinion, even in the best possible scenario, the only good embryo is an euploid embryo. Because we know that even when we do egg donation and we perform PGT on these embryos, there's going to be like probably 30% of these embryos that, despite using the own eggs, we are going to get aneuploidies. And the recent studies that have been published with a lot of hundreds of thousands of patients suggest that if you transfer euploid embryos, the live birth rate, which is the only one that is really important for patients, is going to be good. And if not, you may need many transfers. And then we have this concept of implantation failure, which is very controversial. You know, how many embryos do we need to consider that someone is having an implantation failure? And in my opinion, 90% of the success is the embryo. So the real implantation failure is not that common.
Okay, thank you. Well, you've opened the door up to us talking about things other than the embryo, which I think is important. I don't think we should just focus on the embryo, but you've also explained a lot about aneuploidy. But I'm going to ask you all. I'm going to go around you all again in a different order, and I think you all have said something about, let's say, this blastocyst grade, or even you, Dr. Raúl. I don't think you've said it, but I'm pretty sure in your clinic, if you had a euploid embryo, normal embryo, and one was AB and one was, CC, you'd probably transfer the AB first, right? I mean, is that a fair thing to say? Maybe not.
Well, there are two really large studies from the Lorenzi group from Italy that suggest that once the embryo is euploidy, morphology is no longer relevant, that they have the same implantation rate. This study is based on more than 2,000 embryos. And it's true that once the embryo is good, it is more likely to be normal, the chances of having an euploid embryo. But once the embryo is euploid, the implantation rates do not change regardless of the morphology. On top of that, we sometimes have really good embryos, but if the time lapse has not been perfect, the time lapse tend to offer negative information rather than positive to identify problems during the embryo evolution. We may have AA embryos that are transferred after a BA only because the BA has performed better in the time lapse. So there is multiple criteria, not just the morphology.
Okay, well, I think that's quite good. So I'm not going to ask you this question because you've already kind of answered it in a different way. But if I ask the other doctor, starting with Dr. Zane, so you didn't say this, it was Dr. Hausken, but I'm going to make an assumption here. I can be quite a difficult host, I promise you that. So if you had if we say that AB is good, I think you said good enough or something like that, use some phrase like that. that does suggest that if it's not that, we're thinking it has a lower chance, right? Which I think is a reasonable assumption based on morphology alone. But my question to you is, have you transferred embryos in the past that have had what you would consider poor quality based on that grading, and they've produced babies?
Of course.
Yeah.
Yes.
Okay.
The answer is very easy. Yes.
Beautiful, simple answer. The reason I ask that, I think you can guess why, is because patients, understandably get fixated on the grade because we use words like good, bad, poor, and therefore they see good ones as that's my best chance and poor ones as possibly no chance. So same question to you, Dr. Hausken. You must have transferred embryos that didn't meet this AB threshold, but they still produce babies, right?
Yes, of course. We have all seen that actually embryos that we think it will never happen, but that's the only thing they have. And we discuss it with the patient, and we say to them, okay, we have this, it's still available and alive, so we will put it back, and they all say yes. And then we see pregnancies with that. So the morphology is of course not 100%, but you will of course choose the embryo that you think looks best. You will always start with that. You can't start with the bad one. So but yes, we have, and that's the amazing thing with IVF. You have couples you think they will never have a child, and then they have a success in the first attempt, and then you have couples young and fresh, and you think this is an easy case, and you have 10 attempts. So yeah.
Okay, thank you. And well, I think it's obvious why I asked that question, because I'll probably conclude tonight's session by saying, is it useful? So I want you just to think about it. You don't need to answer now. Is it even useful to be using words like good, bad, and poor? That's what I want you to think about, because I worry when I speak to patients, they do use these words and they're very loaded, aren't they? And you've just told me something that we use the word poor was successful. I realize statistically it might be a lower chance, but to a patient with one embryo, it's an absolute. It either works or it doesn't work. So we'll come back to that at the end. Let's get to the questions now. So let's see. Okay. Let's start answering this. So can you, I'm going to ask each of the doctors, you've said a little bit about it already, Dr. Zane and Dr. Raúl, but I will have to ask Dr. John as well. Is PGTA, I assume they mean, aneuploidy screening, offered in, let's start with you, Dr. Zane, in Latvia. Is it offered and allowed and everything else? Because one of the things we find on these sessions is there are different rules in different countries.
Yes, it is allowed in Europe. In Europe, it is allowed in Latvia for sure. It is not allowed actually to choose genders, to make gender selection. We are asked to choose actually the best embryo for first embryo transfer, but there is no problem with PGT at all. It is not government paid for our people, but yes, for sure, it is allowed.
Okay, so simple question. This patient had 4 failed transfers. I don't know if they were all 4AB blastocysts, but would PGTA be something you were thinking of doing?
Yes, sure, but this would not be the only thing which I would perform. But yes, we would offer PGTA.
Okay, we'll come back to the other things, but I'm just focusing on this question. Dr. Raúl, same question. I'm pretty sure I know what you're going to say.
Yeah, we are allowed to do all kinds of PGT. It's true that depending on which kinds, we may need the government authorization, depending on the disease, especially monogenics. But with regards to aneuploidy and ESR to translocations, no issues. We can do it in any case. And in these cases of patients who recurrently have problems with an egg donation, I would probably check the sperm. I think that the male factor is clearly underrated when assessing the embryo quality, and unfortunately, as it happens with a normal AMH, that does not guarantee the fertility. Having a normal spermiogram does not guarantee fertility.
Okay, thank you. And Dr. John, so I'm not sure of the current situation in Norway, but please say what's allowed in Norway, but also what your own thoughts are as a physician about screening using PGTA, please.
Yes, it's a big question. We are not allowed yet to do PGTA in Norway. But it will come, and I think it's a good idea because we all know about the big study in US. It was about 4,400 couples attempting IVF and only had transferred top quality embryo morphology and also with a normal PGTA. And in the end, I think it was after 3 or 4 or 5 or 6 transfers, they all, not all, but 95% got pregnant. So it is all about the embryo actually, but you open a box because what about the 5%? Because the couples, they think also about the implantation, and there are much to say about also the implantation because you need a healthy embryo and you need an implantation window that will accept the embryo. So we need to discuss that a little bit. But it is also depending on the patients because I do tell couples, okay, I think PGTA is a good idea and I will help you because there are clinics outside this country that can offer that. But it's all about the patient. Let's say we have a woman age 42 and probably she will not have a good top quality embryo at all. So if she has one, we are happy. So I always say, okay, it's all about the number of eggs to create one top quality embryo. So use your money in a clever way. Why should you actually test an embryo? The lady has only one embryo. Should we put it back? Or should we do a PGTA? So it's all about the cost. If the cost is low, I love PGTA.
Okay, well, thank you for that. I mean, I don't know what you know about me, but I've been involved in PGTA for quite a long time in lots of different guises, clinic, manufacturer and supplier of test. That doesn't mean I think it's for everyone. It just means I'm experienced with it. This thing about cost is very interesting. I don't want to sidetrack too much, but I always ask the question, is it safe and worth doing before I even think about cost, right? It's like, is it right to do for this patient? And then we'll figure out the cost. So I don't think the decision should be automatically driven by cost is my thing. There's a next question here is I need some more information for us to answer it. It's the patient who's talking about having 5 IVF transfers all failed, both blastocysts, 2 fresh in 2021. Is it due to my age being 40? But could you put your grades of embryos in because that's relevant to tonight's discussion? Because if they're high quality, then that is exactly on point. But if they're not such high quality, I'm sure everyone will say we'd probably need to get better quality embryos and test them, given that you're 40. So that would just help if you could add that. Next question, and I'm sticking on the theme of embryo quality. We will move to the other issues as well, or let's say what you would do having got good embryos, but it's not working. This question, though, says, I'll try and summarize. Are children from day 5 3 BC embryos, and I think we can just say so-called lower quality embryos, less healthy or intelligent than from day 5 top quality 5 AA embryos? So Dr. Raúl, can you answer that question, but also say anything in terms of what you think the child outcome would be based on embryo quality, please?
Well, I think that embryo quality is basically related to the chances of success and to the likelihood of implantation, but not to any long-term issue in the babies. It's true that we have a limited amount of information. I mean, the first baby born after IVF is now 46, and that's all we can do. And the first baby born after PGT could be now probably 19 or 20 years old, and that's all the information we have. But so far, I don't think that there is any evidence that transferring low-grade embryos lead to unhealthy babies. It's just that your chances, it's It's just that your chances of success are lower. We're having problems with him. Freeze.
I think Alan disappeared.
Yeah.
But I could follow up when he because I agree with you, Raúl. The children are not affected by the morphology grading, and so the grading is not the super tool, but it is the best we can do when we just look in the microscope, of course. But a PGTA testing, because I would say if, let's say you have a young woman with 6 top quality embryos, then it's really important to do a PGTA, because instead of putting back 6 or doing 6 transfer, you can do a PGTA and you will see, oh, there was only 1 and we are going to put back that. So they will save time and money by that. But then you have then couples, they don't really have much top quality embryo, perhaps only 1, and then we could discuss is it necessary, or should we just put it back to see will it work or will it not work?
Yes, PGTA is not going to help us fix anything. It's just going to give us information about the real quality of the embryo. So it depends a lot on how important it is for the couple to know the real quality, because if you have 4 embryos and all are abnormal, you may start considering egg donation rather than continuing with the same protocol and the same treatment, But I agree with you that sometimes when there is only 1 embryo, you can offer the patient the possibility of transferring it. And if you are lucky and you get pregnant, you also have options during the pregnancy to check if the embryo is normal or not. This is difficult when the patients have had miscarriages because they don't want to go through the same problem more times, but is a very good option in cases in which you are not going to select because that's all what they have.
And Alan is back.
Yeah, sorry about that. Internet.
No?
What can you do? Okay. Sorry. Now I'm trying to get back up to speed with these questions. Okay, we answered that one. Right.
So
question about
when you read, I could say something, Alan, or
yeah. What's it about? So I can
because you have to know that we want to help couples, of course, and we know that IVF today is really expensive because there are so many tests that can be offered, and the couples, they don't know anything and they trust the doctor. So let's be open and say this test is not necessary for you, because we need to keep down the amount of money, because now there are so many couples out there, they can't afford IVF at all, and we have to be responsible, not just offering test after test after test. I'm not against PGTA, and I'm not talking about that, but are we going to do to see if the tubes are open? Are we going to look at implantation window? Are we going to test for bacteria? Are we going to do this or this or this? And of course, the patient will follow the advice of the doctor, but you need to stop. Okay, is this really necessary for this couple?
Okay, thank you. I think that's a really sensible approach to things, because the more tests that come along, the more treatments that come along, the more tempting it is for a patient to try everything, throw the kitchen sink at it and see what sticks. So now I'm going to kind of pull it back a little bit. I'm going to go back to the questions in a second, but create a bit more context away from just embryos. Starting with Dr. Zane. So let's assume we're on kind of the same page about what's a good embryo, right? We've talked about grade, and we've talked about possibly having a PGTA result saying it's normal or euploid. So what other things would you start doing to investigate the patient, offer to the patient?
Would I start to do? My internet also is a little bit jumping. What would I do next after evaluating the embryo quality?
No,
sorry, Alan,
you've got good embryos. That's okay.
Yeah.
You've got good embryos. What are you going to do? You can't fix the embryos now. They're good. What are you going to do?
Put it back.
Actually, in Latvia, I will implant it. I will transfer it.
No, sorry. Let me, no. You've had multiple good embryo transfers. What are you going to do differently? Yes.
So at least in Latvia, we rush a little bit. We use quite a lot adds-on which are not recommended so quickly as we usually use. But our rush is due to our system in Latvia, how our reimbursed cycles, at least in Latvia, we really tend to result because at least for our patient, for Latvian patient, reimbursement is only for 2 unsuccessful attempts or as much as we wish successful. Therefore, we usually try with first IVF cycle and do first transfer. This is the first time. The second time we usually recommend to do for their own money. And if it is unsuccessful and we think that embryo is good quality and that we don't see any other obvious reason why it is not implanted, we start with seeking reasons. And one of the reasons is, evaluating of sperm DNA fragmentation, if it is elevated, because elevated DNA fragmentation of male sperm is the most frequent reason of male factor why embryo is not developing or there is spontaneous abortion or miscarriage till 9th of gestational week. Then we usually evaluate both partners' karyotype. If it is not done already before, we always do karyotyping for ladies over 40, or if it is if there are situations or pregnancies with trisomies or in first relative generation, and for those who are with unknown reason or for infertility. If it is not done before, then we do karyotype at the moment. Then we usually recommend to seek for coagulation factors to screen for thrombophilia congenital or obtained thrombophilia. And yes, we do hysteroscopy with endometrial scratching if it is good enough, or seek for chronic endometritis, morphological or immunohistochemical. We do also microbiome analysis as well as endometrial receptivity test. We do not really believe, we always inform how much evidence each of these tests has, and not always and patient is ready to pay or according to our knowledge is ready to wait. But at least after second ineffective attempt, we speak about all these adds-on and treat if and move on forward if we find anything. Did I answer on your question?
Yes. Yeah, absolutely. You gave a battery of different things, sort of in contrast to Dr. John, a battery of different things that you would do after several failed transfers with a good quality embryo. I'm going to ask the same question to Dr. Raúl now, but can you focus on if you differ, if you say I wouldn't do that, or you do something additional rather than repeat the same things, please?
Well, the Spanish Fertility Society has recently released a book assessing the clinical evidence of the different add-ons that we have. And I am honestly, the results are depressing, because we lack of really good studies. I usually say that in assisted reproduction, we are like kind of fashion victims, in the sense that I'm not as lucky as John, that he has patients who trust him. I mean, I have patients that come with this amount of papers that the Dr. Google is not helping at all. And I have a friend who has done this. I have my friend who has done that, we believe in very few tests. We believe in very few tests. Probably because I've seen many trends in my life, things that have come, and once we have got the real information, have proved to be useless, and we have been doing them for quite a few times. And I can mention HLA and uterine receptors, metroplastic of the uterus, the ERA itself. We don't believe in ERA. I mean, I always thought that if an embryo implants in a tube, it's because the embryo really doesn't need a good endometrium to implant, and the embryo is everything. So basically, we test from thrombophilias and antiphospholipid syndrome when it's necessary, and we think that it can. Sometimes we may use anticoagulants empirically. We are now trying to assess if microbioma is as helpful as people suggest, because we are also critical with that, with the contamination. When you take the sample, it's really clear. So there are many controversies around microbioma. And we don't believe in hysteroscopy, for example, if the uterus is normal. There are many studies starting from the trophy and continuing from meta-analysis that confirms that if uterus is okay, hysteroscopy does not increase live birth. So it's a really painful sometimes test that, in our opinion, is unnecessary. Hysteroscopy is limited to confirm what we see in the scan and see if there is anything, a polyp or an abnormality or something, or that when the endometrium does not grow as expected. And that's probably is. I mean, I spend a lot of time in my visit saying no rather than saying yes, because there are many immunology, for example. We really don't believe in immunology, as has been suggested, natural killers, CDs, TH1, TH2. I mean, and there are also many studies that suggest that the treatments, apart from not being completely safe, do not increase live birth. So 2-3 things like microbioma, thrombophilias, antiphospholipid, and not many more.
Okay, perfect. And you know what's coming, Dr. John. I'm coming to you. But if you can do the same thing, like focus on, well, I mean, in your case, maybe there's quite a lot of things you wouldn't do, and that's. But I'm going to ask you to answer a couple of other questions along the way as well, which would be, do you think, what would you do if the patient had good quality embryos, as we've already defined them, but they also had endometriosis or adenomyosis? Would that change any of your management? Because those are two of the questions we've got.
It's, of course, a good question. We know that there are also some issues regarding implantation. So adenomyosis seems to have a lower implantation rate. And why is that? Well, we are all back to the inflammation game, and so we know that the immune system is involved. We don't have the tool and the answers, but we do actually try to depress the immune system in couples that we think could have an implantation problem, and so we use different medication to depress the immune system at the moment at implantation. So, but if it's the first go, I wouldn't do anything. But of course, then we have done 2-3 attempts, and the embryos, they are looking very good. And why doesn't it happen? And then, of course, we discuss with the patients,